welcome back to Psychedelics Today, everybody. This is your host, Kyle Buller. Today on the show, I get to chat with Dr. Jenifer Talley, who is a clinical psychologist and is the assistant director over at the Center for Optimal Living. The Center for Optimal Living does a lot of harm reduction work and harm reduction psychotherapy. I originally reached out to the Center for Optimal Living and Dr. Talley a few months ago for a school project, and I thought it would be fun to highlight the work that they're doing over there. We've talked a little bit about the psychedelic education continuing care program a while back with Dr. Ingmar Gorman and Dr. Catherine McLean. And so this is the other side of that program. It's the parent organization. And they do a lot of great harm reduction work. They have a training program called Integrative Harm Reduction Psychotherapy. That's the model that they use. And I think this is really relevant. We don't talk too much about psychedelics in this episode a little bit, but, just the idea of approaching substance abuse and substances in a way where it's a little bit more humane and really focused on building a relationship with people. I do know that we have a lot of clinicians and students listen to this show. So I thought it would be fun to talk to Jenifer about their harm reduction approach. Because, really, we're a psychedelic podcast, but we're also interested in drug policy, drug education, and harm reduction. And so how could you utilize some harm reduction approach within a practice or just even with your friends? I think that's even really important to just become educated on how you could incorporate any harm reduction approach with your friends or family. If somebody is using, or if there are safety concerns, like how could you approach people with more of like a humane approach, but also with compassion. I think there's a negative view when it comes to different substances, and how could we be a little bit more compassionate towards people that do use, say, opioids or cocaine or whatever that is. Like, how can we become a little bit more curious about why they're using that instead of just shaming them and trying to get them to stop? Because, the chances are there's probably something underlying there. There's probably a co-occurring mental health disorder, maybe depression, anxiety. Maybe there's some trauma. I think there's a lot of trauma theory within substance abuse and addiction. So I think the harm reduction approach is really relevant to the work that we're doing. Obviously, we talk a lot about harm reduction with psychedelics, so why not talk about harm reduction for other things, other substances? And, it's important, testing your substance. There's a lot of contaminants and adulterants out there. I just read something from Dance Safe the other day about potential contamination or adulterant of fentanyl found in MDMA. So this stuff is really relevant. Testing your substances, making sure if you are going to engage, are you doing it safely? So we're minimizing risks, maximizing benefits. And I hope you guys really enjoy this episode. I had a really great time chatting with Dr. Talley, and really grateful for her time and to just share a little bit about the Center for Optimal Living. They're kind of doing some cool work. They're at the forefront of harm reduction, and it's cool because I think a lot of traditional models operate off of a medical model or a biological model. And so how can we incorporate a biopsychosocial model and treat the person as a whole, not as like somebody that's diseased or morally wrong for doing this? How do we approach all this with compassion? So I hope you enjoy the episode. And for anybody that's been listening, I haven't been on any shows in a while. Thankfully, Joe is able to record and keep up with that. I've been a little occupied over the semester with school. And my internship, that was a main thing. I'm clocking away at my internship. I'm almost done with grad school. Whew. It's been a journey to take on grad school and take on this project with psychedelics today. But I'm so grateful for everybody, so grateful for the support over the years. I wouldn't be doing this without your support and everybody listening. So thank you so much for keeping me going, keeping me motivated throughout school, and to keep this project alive. Been really enjoying it. So yeah, from the bottom of my heart, I thank you guys so much for listening and tuning in. If you want to support the show, you could check out our Patreon page if you want to make a donation with that. Or, if you don't have any money to donate on the Patreon, that's totally fine. The biggest way to support is sharing our content, getting it out there. We can share it, but, I think it also gets a little bit further when you share some of our content. So whether that's grabbing a podcast, a blog post, resharing it, or if you're on Instagram, maybe reposting, a piece of content of ours on your Instagram account, or whatever that is, you just share it throughout the social media. And then you could also leave us a review on iTunes, Facebook. Those always help out, especially with the iTunes algorithm, or reviews help us get up there in the rankings, which is very appreciated. We really appreciate that. And also our Navigating Psychedelics course. Harm reduction again. So if you're interested in the harm reduction and you want to learn more about harm reduction for psychedelics, definitely take a look at our Navigating Psychedelics course. We go through harm reduction, testing, and then kind of navigating that psychedelic space. We put a framework on there for understanding some of these transpersonal experiences and learning how to navigate it. We have tons of master classes with interviews from people that have been doing integration work or just been in this field for a bit. So you can check that out. And if you guys have any questions, any comments, anything like that, always feel free to reach out. We always like to hear from our guests or our listeners and guests too. But we always like to hear from our listeners and hear about any feedback that you might have. You can send us an email at psychedelicstoday@gmail.com. All right. Awesome. Thanks so much for listening, and hope you enjoy this episode. All right, welcome back to Psychedelics Today, everybody. I'm here with Dr. Jenifer Talley from the Center for Optimal Living, based in New York City. Welcome to the show.
Thanks so much for having me, Kyle. It's a pleasure.
Yeah, so we connected, I guess about a month ago. I reached out to do an interview, and I was going to kind of do a dual purpose interview because I needed to do something about substance abuse for my school. And so I invited you back on, and we can chat a little bit about what you do at the Center for Optimal Living and some of the harm reduction approach. But how about like a little introduction to who you are and, what type of work do you do in the world?
Yeah, sure. No problem. So I actually grew up outside of DC, moved up to this area when I was doing my internship and postdoc, and then was working at St. Luke's Hospital, working primarily with female survivors of trauma and substance use. And then was connected with Dr. Tatarsky a couple of years ago, right before he opened the center. And then we just really clicked when we met. It was perfect timing. The center was about to open. I was able to join the team right before opening. And then we've just been working together and doing trainings ever since.
Awesome. Yeah, and so you and Dr. Tatarsky have founded this organization, correct?
He's technically the founder. I'm the assistant director. Yeah, it's his baby. And then I came in right at the right time.
Awesome. And what's the primary focus for the Center for Optimal Living?
We're primarily known for our work with substance use and the harm reduction focus that we take, but we can also treat, a variety of mental health issues. We also have somebody on the team who can do yoga therapy, we have an acupuncture. So we try to be as integrative and as holistic as possible in the work that we do and the offerings that we have.
Yeah. Oh, that's awesome. And I know also some of our listeners might know about the psychedelic program, but we can get into that a little bit later.
Yes.
Yeah, awesome. How did you get involved in like the harm reduction work?
I actually didn't know I was doing it when I was on internship, if that makes sense. Yeah. So it was interesting to be able to work in a setting where there wasn't this abstinence-only mandate. And so working with trauma survivors, people with really complex difficulties and challenges, an abstinence-only approach just doesn't work. And so I really became immersed in the work once I moved to New York City. So I was at Princeton House for a while, and then moved to New York, and then really started working with Andrew very closely, and then became aware of his integrative harm reduction psychotherapy model, which is what we use at the center.
What kind of observations have you seen that like abstinence doesn't work?
I think it can be a deterrent for somebody if that's the marker that you set up front. So if somebody wants to engage in treatment and they only know that there is a problem, let's say somebody's concerned about their alcohol use, abstinence might feel like a huge step for them. And to mandate that or to have that as kind of a requirement of starting treatment is really off-putting for people, especially if it's something they've used for a long, long time. They don't have really other coping skills. It's a hard sell. And so I think we're really good at engaging people, at building a really good relationship. And then from there, working collaboratively with our clients to help them reduce risk and then reach the goals that they set for themselves. And so abstinence might be ideal as an outcome for a lot of people, but we just don't start with that as the beginning of treatment, if that makes sense.
Right. Yeah. And it's probably challenging for some people to even think about quitting, right? It's like, whoa, it's a huge step for some folks.
Right, exactly.
And that's kind of been really based off of like the medical model of like substance abuse issues and addiction, right?
Mm-hmm. Right. And I think historically, too, there was this assumption that if somebody's an active drug or alcohol user, they can't benefit from psychotherapy or from treatments. And that's just not the case at all. That oftentimes people come in and they're really struggling, but it's the perfect opportunity then to get help and address the underlying issues, their kind of maladaptive coping skills, and then really understand what's at the heart of their substance use to help them make changes.
Right. Yeah. What type of approach do you take when it comes to like addiction and substance abuse? So, you know, we have the medical model, the biological model, moral model, and then the biopsychosocial.
Mm-hmm. We definitely use the biopsychosocial model, and then Andrew actually talks about it as the psychobiosocial model, where the emphasis is on the psychological factors. And his training in relational analysis, I think, really does inform the model that we use at our center. And so at the heart of it, it's really about the relationships that people have with substances, frankly. You know, so what kind of relationship do they want to have with alcohol? What would that look like in an ideal sense? But then also the relationship they have with us as the providers, with people in their lives, with the culture, with society. So really taking a relational framework, I think, is important, and contextualizing their substance use and trying to understand the big picture of it.
Right. Yeah.
And then my training's also been in incorporating like mindfulness-based strategies. I got my PhD at Virginia Tech, so my training was much more cognitive behavioral.
Okay. Awesome. How do you view, I guess, certain addictions or substance abuse? Do you see it as like a disease in the brain or anything like that?
I don't tend to think in those terms.
Yeah.
I really do tend to think more along the lines of what Ed Cancey talks about with the self-medication hypothesis, that people really do struggle with these vulnerabilities and self-regulation, these deficits, if you will, in managing their emotions, managing relationships, managing conflicts, you know, not having adequate self-care. And then oftentimes trauma is often a player or, you know, a factor in why somebody might then rely on a substance as a form of coping. So I see substance use as a symptom of like a bigger issue. And then I turn towards it with curiosity, with openness, with compassion to then help people think through like, well, how do you want this to be in your life? What would that look like ideally?
Awesome. And something you said about relationship being like a cornerstone of this approach as well makes me think. I saw a TED Talk. I forget the guy's name, but you've probably seen it if it's in this realm. But the one thing that stood out, it was like the opposite of addiction is connection.
Right.
Yeah. Just that idea.
That's Johan Hari's work.
Yeah, Hari.
Yeah. Yep.
So yeah, it's fascinating to maybe view it through that. And I know that doesn't always fly in, say, medical models and whatnot, because they're
right. I think the medical model decontextualizes it, right? It localizes it just within the person. And I think often substance use is an expression of something that could be happening in a relationship, right? I'm supervising one of our clinicians right now, and one of her clients is misusing alcohol, but there's like a clear rupture in his relationship with his wife. So his alcohol use almost makes perfect sense if you can step back and look at what's happening in the system.
Yeah.
Right.
Yeah, sometimes we got to look a little wider and broader and look at the bigger picture to really figure out those smaller little details.
Right. So it's almost unfair to ask him to change without the system itself also changing.
Right.
Yeah.
So let's, I guess, jump a little bit into the integrative harm reduction psychotherapy. What is the story behind that? How did Andrew come up with that? And
Sure. So Andrew's background is that he was actually trained at City College. I think he got like really solid like psychoanalytic training, but he also worked with somebody who was an integrative psychologist. So he learned about other traditions as well. And so one of his first jobs was at a more traditional addiction treatment center where, as he puts it, he was doing things that were almost like the opposite of how he was trained in graduate school. And so the field at that time was very much about the disease model, more of like a confrontational, abstinence-only approach. And he found himself really questioning that model and the efficacy of that model. And so he started to experiment with harm reduction without really knowing, again, what that was or what he was doing, that there was like a term for it and that it was actually happening in England at that time. It was really flourishing in England, just where it originated. England and the Netherlands is where it originated.
Europe always seems a little bit ahead on humanistic approaches.
Oh, totally. And so as he started experimenting with working with active drug and alcohol users, I think something really clicked for him where it's like, no, I can still utilize all of these skills that I learned in graduate school and still use my relational analytic framework. And I can also work with active drug and alcohol users to help them make positive change. And so he also had a relationship with Alan Marlatt, who's considered the godfather of harm reduction in the United States. And so I think was also in dialogue with Alan at that time. And Alan said, Andrew, you're doing harm reduction. Like he named it for him. And then over time, Andrew then really kind of fleshed that out into his own model. And so I can describe it for you if you want. So there are 7 therapeutic tasks within the model of integrative harm reduction psychotherapy. And so the first task is this notion that the therapeutic relationship heals. And so really that's at the heart of the approach. And so when I think about that, I think about how we set the tone for the treatment process. It begins with the first call, the first email. People are just profoundly ashamed and just anxious about even admitting that there's a problem with drugs or alcohol because there's so much stigma in our society right now. So I think we're very sensitive to that and to the ways in which, people might be really anxious about even disclosing what their use looks like. And so we're really careful about, creating a safe therapeutic relationship with our clients where, the focus is on collaboration. Alan Marlatt talked about harm reduction as compassionate pragmatism, which I love because, we're pragmatic in the sense that we accept this reality that people are going to continue to use drugs and alcohol. This is just reality. So how do we work within that reality with our clients in a way that's compassionate, that's collaborative, that's integrative? And so that's really how I think about the model. And so the relationships that we build with our clients really is kind of like a venue then for the healing process. And so the therapeutic alliance and the relationship are the first 2 tasks. And the third task is enhancing self-management skills. And you could think about that as, strategies for, the change process. So how do we then, help people really develop coping skills? How do we help them better understand how to work with cravings? And the data on mindfulness-based relapse prevention, for instance, really does highlight the importance of helping people shift how they relate to cravings. And so we often hear that cravings are something people have to battle, right? Like, I have to get rid of this craving. It's bad.
Right.
And we take an opposite approach where we actually turn towards the craving with curiosity, with kindness, because there's a lot of data there, information about what's really needed. What's driving my urge to have a drink right now? What's this underlying need that might not be expressed with words? It's getting expressed through action.
Right.
And so helping people develop these just capacities to tolerate discomfort too is important.
What have you found some of the roots of some of these cravings when you've been working with people?
Loneliness, boredom, sadness. When I was doing more trauma-related work, it was being triggered, hypervigilant, having intrusive memories or symptoms of trauma that were just being bombarded by these memories and feelings in the body, discomfort. And then really seeking relief, it's really an attempt to self-soothe is how I see it. And then how do we help people develop other, maybe less harmful ways of self-soothing?
Yeah, makes sense.
Yeah, so that's like a really important part of the work. So we do like kind of tangible like skills development with people, but then we also do deeper work to really get at the underlying meaning, the function of their substance use. And then, we move into what's called assessment as treatment as the next phase of the model, where we then help people do what we call a microanalysis of really almost like a postmortem of looking at if there was like heavy use over the weekend. So it's not uncommon. We see a client, Monday, Tuesday, Wednesday, there's been, a big bender or binge over the weekend. And then our job is to really like understand what happened, again, in this way that's not judgmental, it's compassionate. There's this curiosity that we bring to it. And then, we're like little detectives. We're just trying to understand so what happened next? What were you thinking? What were you feeling? You had a craving. How did you respond to the craving? What was the narrative around it? And then what did you do? What were the action steps that you took? And then what did you do? What was the use like? And then what happened afterwards? I'm working with somebody who, as an example, used a lot of cocaine this past weekend. And at the time, he thought it would help him get through all the holiday parties that he had to go through. So that was the belief on Friday night. Okay, I need this. It's going to help me. I'll be more effective. I'll be able to get through all of this. But then, Monday morning rolls around. He's embarrassed. He's questioning, oh my God, what did I say at the party? Did I make a fool of myself? And then like this real strong depressive feeling is there now. And so the work going forward is helping him kind of connect the dots. So when the craving for using Coke happens on Friday night, can he think through and imagine what Monday morning might look like? And how do we then mitigate the risks associated with his use so that he's feeling less depressed Monday morning, less anxious about what he might have done or not done? Right. And so then we think through, ideally, what would that look like in the future? So it could mean reducing his use, using less, taking a pause when he feels the craving or what I call the pro-use thoughts, the pro-Coke thoughts. And then it might mean abstinence, for him. It really just depends on what he wants to do with it once he gets a sense of like what the process looks like. Mm-hmm. So really the client is in the driver's seat of the goals that they want to work on. I mean, this is barring like real severe like safety risks. If somebody is, in need of more stabilization, let's say need a higher level of care, we certainly recommend that, but that is how we work.
Yeah, that's something that always comes up to me, like when I think about harm reduction. It's like, and I guess, this kind of comes up to a question that just popped in my head. Like any challenges that you've had when facing this? Because I know for myself, like having clients come in and talk about it, there's part of that. It's like, oh, I need to like help them. And like, how's that been for you? Like, was that really challenging early on doing this work? Or like when there is a safety thing there, like how do you step in and really best quote unquote serve them? Right. Like maybe without putting our own agenda in there.
Right. And I think you're hitting it, right on. Because I think it is, I think that's the art of this work. It's that really trying to come in with no agenda other than to be helpful and reduce risk. But at the same time, these are people that we care about. We don't want really scary, dangerous things to happen to them. And so what I found over time is that I'm actually very transparent about my thinking process in session. And so I might be debating what direction to go in. I might actually just say that to the clients. I might say, listening to you right now, I'm finding myself feeling anxious or just worried about what's been happening for you. I'm wondering, how do you want us to handle this? What would be reasonable? What would be realistic for us now in terms of a next step? So I might just kind of reflect what I'm thinking and feeling, but then put it back on the client. And then he might say, yeah, you're right. I really don't want this to happen again. Okay, so great. So let's think about how we might then change that for the future. I don't know if that helps answer the question, but I'm very transparent about my own thinking. And then I give people options about like, okay, so what do you want to do with this now that we're aware that this might be an issue?
Yeah, there's a couple questions coming up, and then I also want to get back to these 7 tasks so we don't get too off. So we had the Therapeutic Alliance and then the Relationship Heals, strengthening self-management skills, and then assessment as treatment.
Right.
And then what was the next one we're on?
The next one is embracing ambivalence. And so this, I think, is also a really common part of the work where people just... they might have different parts of themselves. So one part might be really motivated for change and is like ready to do the work and is ready to work on whatever the goal might be that we address. There might be another part that's saying, oh, hell no, I want nothing to do, right? It's more about like just maintaining the status quo, to speak in MI language. And so I think the work really is to help people just give voice to those multiple parts of themselves. That there might be tension, there might be a part that's saying, yes, I want to change. No, I don't want to change. This is really scary. I don't even think I can do this. F this.
You're right.
And I think as clinicians, we have to be on the lookout for that, because we can inadvertently align with the part that wants to change. Right? And frankly, it's easier, right? Oh, great. So let's do X, Y, and Z. Here's the plan. Without then pausing and saying, okay, so we just talked about what you could do this weekend to use less Coke. But is there another part of you right now, or another voice that's saying, absolutely not? So we explicitly try to draw out the part that might be not quite ready to make that change. And then we just have a dialogue with that part.
And so that part, kind of just bringing that part of themselves out and engaging in it. Gotcha. So you guys also do a little bit of parts work there, I guess, as well.
Yes. And then I don't know if you know the work of Scott Kellogg, who does transformational chair work. No. So some of the people on our team have been trained in that approach as well, where it's like Gestalt psychotherapy, chair talk, chair work.
Yeah. Okay. Cool.
Chair talk. Yeah.
I think I know what you mean. Yeah.
Yeah. And then the next part of the model is goal setting. And so this is when we then really help clients think through not only their substance use changes, but like bigger kind of lifestyle changes they might want to make. So it could be looking at their fitness, their diet, their self-care activities, their relationships, their work-life balance, unplugging from technology, unplugging from email, their phones, but then also really developing very explicit substance use-related goals. And that could be, just as an example, one of my clients wants to drink no more than 4 drinks at a time, maybe no more than 2 or 3 times a week. So that's kind of the target that we aim for each week. And then we have like a variety of other strategies and other plans that she puts into place to ensure that she reaches that goal each week. And she's tracking, she's paying attention, she's practicing mindfulness.
And do you have people typically track stuff, like write things down, or is it just kind of like, they can kind of do whatever they want in tracking sense?
I think we're fairly flexible in how we work with people. So if some people are really put off by that, we would never require it. But I do think there is a lot of benefit to just keep noticing, keeping track, having some kind of log of what's happening. Some of my clients will use apps. Others will just track like on a journal or a piece of paper. Awesome. But it can be really useful. Yeah. And then the last stage is the personalized plan for change. So we call that the optimal use plan. And so it's, asking people to really evaluate, if we're to minimize the risks of your substance use and maximize the benefits, what would that look like for you? And that will evolve with time. So in the beginning, somebody might really not be motivated to do too much. And so in the beginning, it's just noticing, tracking, monitoring, and then over time, starting to make very subtle, small changes to their use. So maybe it's not having a drink right when you get to the bar, it's having water, taking a couple breaths, kind of orienting yourself, and then making the decision to begin to drink with the goal in mind. Right. And then for other people, it's experimenting with abstinence at times.
Right. Yeah, that seems, I don't know, very collaborative and probably the best way to approach some of this stuff, instead of like coming in and be like, no, we need to like get you not to do this. It's like, how do we develop a relationship with these substances or these behaviors or patterns, and really kind of be curious about it? I mean, it seems really important.
Right. And that I'm an ally, I'm a collaborator in the process. I'm not the expert.
And to kind of go back to like, say, a challenge, like, did you experience any challenges for yourself as a therapist engaging in this work early on? I know you've been doing this for a while, but just like early on, it was just like, ooh, like, how do I really approach this? I know you said you kind of been doing harm reduction for a while in that sense, but just like, I guess your views on substances and whatnot, like, what were those like in the beginning to where they are now?
Oh, okay, sure. I think I've always had like a progressive mindset about drugs in general, and think that for the most part they should be legalized and regulated, just period. So I come from that kind of background. But I do think that at the beginning, when I was working with clients who were using, harder drugs, for lack of a better word, I would get anxious and, really worry about their safety. But I think as I became more acquainted with different drugs that people use, different routes of administration, my comfort level grew. And I think that it just makes intuitive sense to work in this way with clients. Unfortunately, I was never exposed to the disease model or the abstinence-only approach in graduate school or in any of the settings I ever worked in. So I just approached it as like just regular therapy, and then we're just working on behavior change. So that's really where I come from. But I think I did have to work on managing my own personal anxiety about risk and what the work that I was doing. And that's what supervision, consultation was for.
Right. Yeah. Or even any judgment. Like, it didn't sound like, yeah. Yeah. That's probably a hard thing.
Right.
Especially, because I think like in our culture, we have such a, I don't know, negative view on a lot of drugs and substances. And so, yeah, how do we like show up for ourselves and maybe not be so judgmental when it comes to somebody using or whatnot, and think about their safety.
Right. And to really understand they're using it for a very specific and very meaningful reason to them. Right. And so my job is to really uncover that with them.
Yeah. Yeah. To be curious. It almost sounds like, I don't know, like how many people are curious about somebody's substance use in their personal life to just kind of explore that with them and like explore their humanness and why they are doing this.
Exactly. And there's just so much shame. So I think that's also what I respond to. It's like just being very sensitive and attuned to the shame that people have and how risky it might feel to disclose this to somebody.
Yeah. Yeah.
So I feel very protective of the people I work with.
Nice. Yeah. Yeah. So there was a question I asked you when we chatted last about people coming in intoxicated. And you shared an interesting story when somebody did come in very drunk, and that was like their motive to change. And so, yeah, how do you work with people that might come in that might be intoxicated or under the influence?
We get that question a lot, actually, when we do trainings. I think first you have to assess risk, right? So does that person need medical attention right now? Right. So you're kind of doing like a risk assessment in the moment. And I guess depending on that, you're going to respond differently. So in the case of the client that I was telling you about, risk was relatively low. I mean, he was a heavy, heavy drinker, and he'd been drinking that morning and then came into his appointment with me. But he was able to engage with me and we were able to have a conversation. But I also wasn't comfortable letting him go home. And so what I did was I let him just basically wait it out in my office. I gave him water. If he wanted food, we gave him some food. And then when he was able to go home, he called me the minute he got home. I made sure that he got home safely. But then once I met with him after that had happened, I was like, what is that telling us? Again, approaching it with this attitude of curiosity and compassion, like what is that, that your use has gotten to a point now where it's hard to control it during the day. That's what's happening. That's what I witnessed. And he's like, yeah, it feels so unmanageable right now. I'm just drinking round the clock. I'm exhausted. I'm tired of this. I'm like, okay, so what's our next step? Do you want to think about going into detox, residential program? And that's when he ultimately made the decision to go into detox. And he was abstinent for about 2 to 3 months, actually, after that.
That's wonderful.
And then began drinking again eventually. I mean, he had a lot of stressors in his life. Yeah. But now he's working full time. He has an apartment. He has a roommate. He's now thinking about dating.
Oh, awesome.
Yeah.
So
but yeah, totally. But imagine like a different approach where if he came in intoxicated, I shut him down or said, I can't see you. I'm not going to work with you. You need to get out, go inpatient now.
Right. Yeah. I feel like I almost jinxed myself asking you that question. So about like a week later, I was in the process of doing an alcohol and drug assessment with somebody within the past few weeks. And I was meeting with them for their last session, and they came in extremely stoned. And, they were kind of like shut down in a sense and really anxious. It seemed like, oh my God, he knows that I'm really stoned. And, I was able to kind of laugh about it in the moment, but, I kind of ended the session there, but I emailed them back and was like, hey, listen, like, I don't know. It seemed kind of like we didn't really get too far with that. Can we just come back and, just have another closing session? And they were really worried that they're going to be in trouble. Like,
right.
And I'm like, well, no, you're not in trouble. Like, I'm more worried about your health in a sense, but, and it was really interesting. They were really hesitant about engaging in any sort of therapy or wanting to make any changes. And so I explored that on this last session with them of being like, what made you decide to eat an edible before coming in here? And, they had no idea that the edible was going to be that potent or last that long. And so I did a little psycho ed on that of like, yeah, that's... you got to be careful with that. And by the end of it, they're like, I really feel like I should probably enter into therapy. And, kind of taking your approach of like, yeah, maybe there is something deeper here to explore without trying to shame them. And I was just really shocked they came to that conclusion. I didn't ask them about therapy again. And they just naturally kind of came to this conclusion after I asked, like, why did you decide to eat an edible before coming to therapy, knowing that you had this appointment? And they're like, yeah, maybe I am being a little reckless.
Mm-hmm. So they became interested in talking about it with you. You opened that up for them. Mm-hmm.
Yeah, and I think just that comfortable space of like, I'm not gonna, I'm not getting punished. Because I work in a college setting, so I think there is that sense of like, I'm gonna get in trouble for this right now.
Drugs are bad.
Drugs are bad,
right.
yeah. But also, part of the college life for a lot of people, and how do we reduce harm there so people aren't doing really risky things.
Exactly.
Yeah. So I appreciated that. I felt like I jinxed myself as well.
Yeah, but you handled it beautifully, it sounds like.
Yeah. So we'll see if they come back next semester. I'm excited if they do, because I think there's a lot of stuff to work with there. So I remember reading something about the harm reduction model, and that, it's kind of like a controversial thing here in America. In Europe, it's obviously a little bit more accepted. And part of the reason for this is because harm reduction can sometimes lead to decriminalization. And I think there's somewhat of a fear here in like America against substances in general. What's your take on that? Like, just, I guess, the harm reduction approach in general, like within these traditional frameworks, and why would there be some resistance to incorporating this framework?
I think part of it has to do with the way the addiction treatment system is. I mean, there's like so many ways to answer this question, so I'm trying to think through it. I think one is that there's this gap in our training as clinicians, as providers. And so in this country specifically, a lot of people that ended up becoming substance abuse counselors were people that they themselves were in recovery and had a lot of experience with 12-step self-help groups. So of course, that's based on the disease model, and then complete and total abstinence. I think that's still part of the culture here in this country. And so a lot of treatment settings have adopted that model as their model. And so I think that there is this anxiety and fear about, well, what does it mean to work with an active drug and alcohol user? Can they actually benefit from treatment? And there's still this like moralizing way of thinking about drug and alcohol users. I think there's a lot of stigma and shame, even the way we talk about it, addict, alcoholic, junkie. Yeah.
Yeah, that was something I came across too. Like, it really challenges a lot of these possible rehab centers that rely on the biological model for their business model, and could possibly like, wow, this isn't actually working anymore, and we might need to change our model.
Right. So I think part of the fear is that it sounds like we're condoning substance use. I think there's still this misconception that if I'm a harm reductionist, I'm against abstinence, which is just not true at all. I just don't lead with abstinence. And for some people, that might be the end goal. That might be the end result. But I don't assume that that's appropriate for everybody. And I don't lead my work that way. Yeah.
Okay. So that's an interesting thing about condoning use. I think there is... I don't know, like being a clinician, trying to navigate this, there might be some worry about that. Like, how do I incorporate a harm reduction approach, like, into my practice or where I'm working without trying, coming off as condoning drug use? I mean, I think that is a worry for some people.
Definitely. But the way I think about it is it's happening already. Yep. And I think the ways in which you interact with your clients really sets the tone and what they're willing to share with you or not. So I think to the extent that we can be non-judgmental, even neutral about substance use, to the extent we can be, that's better, because then the clients will really tell us exactly what's going on, and then we can be more helpful.
Do you have any advice for like either clinicians or people that are interested in maybe incorporating a little bit of harm reduction approach? Like, I know you guys have a training and everything, and we get a little bit into that, but I don't know, just any general advice on maybe how to utilize a harm reduction approach in somebody's practice or where they work?
Yeah, well, I think maybe just thinking of like the first step might be just to notice your own like biases and like your own, as Andrew puts it, like your social countertransference about drug and alcohol users and your expectations. So maybe just like kind of like your own like self-assessment, and then getting informed about the model. So there's Andrew's book, Harm Reduction Psychotherapy. Pat Denning and Jeannie Little, who are kind of our counterparts in San Francisco, have wonderful texts on harm reduction therapy. They also have a really good book for clients called Over the Influence. So I think just kind of soaking up the materials and reading about the model can be like a useful step. And the way I think about it too is that we're not doing anything radically different than like what good psychotherapy is. I think that the shift is in our attitude and our assumptions about drug use and how we think about it.
Yeah.
It's not fundamentally different work.
Right. Yeah. It doesn't sound like it, of being curious about somebody's experience and why they're engaging. But yeah, I think sometimes that judgment comes up of, they're doing something bad and it needs to stop, or they need this higher level of care, or whatever that is.
Right. And that's like the knee-jerk reaction. Oh, they're drinking. Oh, they need to go to detox or rehab. Well, not always, not necessarily.
Yeah. Yeah. Yeah, I mean, it's interesting even seeing some of my own reactions of like wanting to kind of move in and help them, be like, oh, like, because I am in that traditional setting where it's like, ooh, what do we do here? They are doing this. How do you approach it? Yeah, it's interesting kind of being in traditional models and navigating that as well. That's one challenge that has come up for me over the past years of trying to not have it to be like, okay, we need to fix this because something is wrong. But that traditional model kind of like influencing you to feel that way at times. Right. And we've been kind of playing around with this notion of like optimal living, right? So what is optimal living? I think our job is to help clients build a life that they're really proud of, that they're happy with. And so that might mean looking at their relationship to substances. Yeah. Yeah, the relationship to substance is huge. I remember one time I was sitting around a fire and somebody was smoking a cigarette and they were passing it back and forth. And this person said, "No, thanks. That's my dose." And I thought about that. I was like, that's my dose for nicotine. I've never really heard anybody say that before. But it really got me curious about what type of relationship does this person have with nicotine, where they even know their therapeutic dose or whatever dose that is that they're looking for. I thought that was really interesting.
Yep. It sounds like what we do with our clients too. Like, what's your, optimal dose of alcohol a given week?
Yeah. And I think, sometimes people don't even think about that of like, oh, there's something that I might be looking for in a substance, and what's the dose to get there? And, if I go past that, okay. But
yeah. And often there's a point of diminishing returns, right?
Right. Yeah. Yeah. And so you guys don't do any other sort of like harm reduction, like needle exchange or anything like that. You're more in the psychotherapy realm.
Exactly. We do training, psychotherapy.
And so what's the training about, the integrative harm reduction psychotherapy training?
Sure. So we have a training actually coming up in January. So the 18th, 19th, and 20th. And so we think 3 days is an ideal amount of time because we really do go through all of those 7 therapeutic tasks that I described in a lot of detail. And so the first day of the training is kind of like an orientation overview of just what's happening in the culture, the models, the historical context, a little bit about epidemiology, and then the different addiction models that exist, and then kind of why, we feel like there needs to be a paradigm shift and a move towards, a more harm reduction focus in the work that we do. And then days 2 and 3 of the training, you really get immersed in the 7 therapeutic tasks. We do role plays, we do case vignettes, there's a lot of dialogue and discussion, and then didactics that we lead.
Awesome. And this is a certificate program too, right? Like you get a certificate afterwards, and then you could integrate that into your practice if you're a clinician or anything like that.
Yeah, so the 3-day training is part 1 of the certificate program, and then part 2 would be taking 15 weeks of classes with Andrew and I.
Oh, okay, cool.
Yeah, so we're actually starting the first online version of our certificate program in February.
It's exciting.
So we have 20 people that have signed up so far. So we'll see how it actually goes. But that we've been getting requests from all over the country to do something that's online and more accessible. So this is our first
that
venture.
was going to be my other question. Is this just based out of New York? Would people have to come in person, or it sounds like you do have an online component to teach?
Yes. Yeah. So for the past 4 years, it's only been in person. And then this is the first year that we're going to do it online. So we're going to use Zoom, and it'll be a live class online on Zoom.
But that first part is an in-person, and then you could do the online. Okay, that's awesome. So, people interested. I know we have a lot of therapists and clinicians that listen to this show that are probably interested on how do I incorporate harm reduction into their work. So, it's great to know that, there's an online component as well. People.
Definitely.
And so I know you guys, the Center for Optimal Living has been around for, you said, about 7 years so far. How has it been received doing this work?
I think when we first opened, I would say it did feel a little bit like a risk, meaning if we really put it out there that harm reduction is what we're doing, what's the reaction going to be? Are people going to refer to us? And in the beginning, I think that people did, I don't know if to have trouble with it is the right way to put it, but people were a little bit more hesitant about referring to us. But over time, I think as people saw that we're doing really good work and that we are actually really able to engage people that might have gone through many other treatment settings and not done well or dropped out or were like treatment failures in quotes because they didn't want abstinence or weren't ready for it. We see a lot of like more high risk, complicated clients. I think we do really well with them. And so I think we've been embraced by more traditional agencies and organizations, and they're now referring to us as well. Ones that, in the beginning, I think were not as inclined to refer to somebody like us. And so our business has actually been growing a lot. We've hired new clinicians over the years just to keep up with the growth of the center, which has actually been amazing and somewhat surprising, frankly, to see, because it did feel like a gamble when we first opened.
Right. Probably pretty scary, kind of pioneers in this new field. But I think, a lot of things are changing. I mean, you're just looking at the legalization of cannabis, and you're seeing these initiatives now in Oregon and I think just Denver about trying to decriminalize psilocybin, so I think part of the narrative is starting to change. And now I'm really curious too on like how people are viewing this with the opioid epidemic and I think we need to look for new approaches.
Absolutely. And interestingly, I think because there's now more funding, we are getting approached from agencies and organizations to do trainings for their staff. So awesome. We're partnering with the Department of Health and Mental Hygiene in New York City to do trainings for them. And then the state of Florida has reached out to us, and we're going to train regionally the state of Florida, the Department of Health there, and their staff.
Oh, no way. That's really exciting. Congrats on that.
Yeah, thanks.
Yeah, so it sounds like there is a need for this work and things are shifting.
Right, because that old model just doesn't suit everybody. And you can't come in with this like assumption that everyone's going to want the same program. You have to really tailor it to each person.
Yeah. What's been one challenge for you or the program as a whole, like kind of being a pioneer in this new, I guess, paradigm of trying to shift that traditional model more into a harm reduction model?
I'm trying to think. I think some of the challenge, and this is a minor challenge, is working with young adults and teens and families. And I think the idea of harm reduction might be less appealing to parents who might want to come in and have us kind of like force abstinence on somebody. So I think we're doing a good job of like working on educating families and parents about the importance of our model, and just educating them on the nuance of what we do versus like I get the appeal of like abstinence only in that case, right?
Right.
Or shipping somebody off to a rehab that's going to supposedly, get them sober. So I think that's the challenge still, is like working with families and parents, if that makes sense.
I could see that being a huge challenge, because it is like, how do you really approach this stuff with teenagers or young adults, where it's like, you want to say, don't do this stuff, and really try to stop them from doing it. But in the sense of like, a lot of addictions start at that age. And if you could take a new approach and maybe help them understand why they're doing that and have honest conversations, could that shift? But again, yeah, I guess it feels risky because it's like, no, you shouldn't be trying to approach this way with teenagers. Yeah, that's interesting.
Yeah, and a good resource that we recommend to parents is the Drug Policy Alliance has Safety First as a resource for parents. And then Robert Myers developed CRAFT, which is community reinforcement and family training. And so we use that model in our work with family members. Really, it's about motivating loved ones to get help, but it's also working with the concerned family members on shifting their expectations, looking at how they're communicating with the person that might have the substance use issue.
Have you ever worked with a teenager or like maybe young adults, but any teenagers come to the center? And how do you approach that?
Yes, definitely. We have a whole young adult program.
Oh, awesome.
So Eddie Einbinder is on our team, and he's kind of our young adult expert. And then we also just recently hired a new family therapist Kristen Thompson Bader, who's going to work primarily with families and do some programming, like some groups and educational activities. I think it is a challenge, and what we're finding is that it's really important to get the family involved in treatment as soon as possible, because for some people, they just want the young adult in treatment, and they themselves might not want to be engaged in the treatment process, and we think systemically, and so it really is important to get the buy-in from the families to reinforce what we're doing, and then we also work, closely with the young adults to really understand the nature of their use, provide, accurate kind of psychoeducational information about risks and risk reduction, but then also getting at like what are the co-occurring mental health issues that are also possibly driving the use, and then what are like the family kind of relational dynamics that could also be exacerbating the use, and then how are we addressing that in the context of like family therapy.
Right.
Yeah.
Awesome. I don't know how true this is, but I read this statistic in one of my substance abuse books or some article that they sent off about the older generation. Their vice is alcohol, and people are starting to see a lot of young people really struggle with opioids. And I guess partly that might be true, but yeah, I wonder if you have any experience with that, or have seen anything like that in the substance abuse world.
Certainly the trend that we're seeing with the young adults that we treat is opioid use, Xanax use, a lot of cannabis use, and alcohol use. Yeah. And then mostly now my work is focused on adults. And for whatever reason, my caseload now, mostly alcohol or cannabis are their main issues.
Okay.
But people on our team see a range of other problematic substances.
And how would you approach cannabis, say, for like a teenager, young adult? I know there's, I think I used to work with teenagers, and it was always somewhat challenging. They start reading this stuff of like, but it's legal here, or it's starting to become legal, and there's health benefits. And, so how would you approach that with somebody?
I think you have to be really careful, because I think if we come too hard on the line of like abstinence, we're going to lose them, So I think it's also trying to provide like balanced information about the potential risks to cognitive development, because there is some data that says that, with early initiation of cannabis use, it could affect in some ways. I mean, I don't think it's like extreme, but it could affect memory, learning, and cognition and attention. And if they already have these vulnerabilities, if they already have, let's say, attention deficit, and they're also smoking cannabis, that could set them up to have some more executive functioning deficits. So I think we would want to just kind of tread lightly in providing that information, and then helping them, again, think through like, why am I using this? What's my reason for using this? And what kind of relationship would I ideally want to have with this substance? And then thinking through the future, what will my use look like next year, the year after? So helping them also imagine the future, and then how their use might play out in the future.
I like that. Do you see, I know you guys have the psychedelic program, but do you see anybody that comes in for, say, wanting to optimize psychedelic use or anything like that?
Yes, I personally don't do that work, but we have the psychedelic education and continuing care program. So Ingmar Gorman, who you might know, is the director of that program. And Elizabeth Nielsen is one of our clinicians as well. And so we actually now have 2 groups for psychedelic users. We have one that's an integration group, and then we also now have a trauma-informed group for people that might have been part of a research study, like the MAP study for MDMA with PTSD, or who've done their own, ceremonies where they might have used substances to deal with their PTSD, then to come in and have a special group that's just focused around psychedelics and trauma. And so we certainly, legally, we're not giving out psychedelics at our center. That's a question that we get. No, we're not doing that. But what we provide is what we call psychedelic harm reduction. And so it's really giving people, up to date, research information about the risks and benefits of using psychedelics, helping them think through their choice to use or not use. We don't give, referrals out to, underground providers. We don't make recommendations
sure you guys get that
to
question
get it.
A lot. We do.
We do. Yep. But somebody might be planning a trip, but they might leave the country, travel to Mexico to be part of a ceremony. And then we just help them prepare for it, think through what they might need to be thinking about and, helping them develop like grounding and coping skills. And then when they come back, we can help them integrate and make sense of and metabolize the experience. Unfortunately, we've heard, of some settings where people are actually traumatized, when they've left the country and done, ayahuasca ceremonies in other countries. And, there have been, accusations of like sexual misconduct in these settings, unfortunately. So we have heard of that, which is really upsetting and frightening to hear about. So we actually,
common. Yeah. It's really common. And it's, it's sad, and it's definitely a challenge. And I think it's obviously growing as psychedelics become more interesting or just more in the mainstream for people.
And people need to be really cautious whenever they decide to do something like that.
Yeah, for sure. We had Ingmar on to talk a little bit about the work there. This is, I think, in the beginning, and we had Catherine on when she was around. But have you seen a lot of growth in that? And I'm sure we could talk to Ingmar in a future episode, but just wondering how the growth has been. Especially even after Pollen's book was released. I'm wondering how large it's grown since. He and Elizabeth are at capacity. They can't even take on new clients at this point because they're just so busy. So we've trained 2 of our other clinicians in doing this work just because of the overflow. And so what Elizabeth and Ingmar are also doing, just in response to the need and the interest, is they've developed trainings for clinicians. So we're calling it Psychedelics 101 and 102. So they also want to help other clinicians who might be seeing this in their practices learn how to work with it effectively. And then we've certainly had to expand our services, and we now offer those 2 groups. And we're thinking about doing some kind of like more public offering as well, because Catherine used to lead these groups that were open to the public, that were more low cost. And I think in the future, we're going to go back to offering something like that as well. That's a little bit more low threshold. Okay, cool. Yeah, she used to do like a more peer support type group. And then Elizabeth, she's doing more of like group psychotherapy. Is that correct?
Exactly. Right.
Awesome. I'm just looking at time, making sure. I know we're probably getting to the hour. So anything that like you're excited about within this field, or like anything you're looking forward to?
I'm excited to see that more and more people are embracing harm reduction. And I think that there's a lot of potential, is how I think of it. And my hope is that in this culture, this is going to be embraced as just the way to treat substance use, hopefully. Yeah.
We chatted with Mitchell Gomez from Dance Safe a while ago, and he made this comment that, we're in like a totally new era of drug use. Fentanyl is showing up in things that don't make any sense. I just saw the other day that Dance Safe released a public announcement that they could have identified a potential contamination of fentanyl and MDMA, and there was a death related to it. They're not 100% sure. They said they would keep people updated, but I mean, I'm sure that even comes across with people using cocaine. I read something a while ago that New York has a lot of contaminated fentanyl in their cocaine. Yeah, it's scary. And I think a harm reduction approach is necessary to teach people how to test and like just understand what they're consuming. And it's starting to become really scary. I think there's been about, I don't know, say 10 or so deaths in my town from overdoses. It's just like, whoa, what is going on here?
Yeah. I guess the other thing, it just made me think, the other thing I'm excited about too is just changing how the family thinks about substance use and their involvement. I don't know if you're aware of Families for Sensible Drug Policy.
I haven't heard of that. I know students have sensible drug policy. But, families,
Yeah. So they're doing a lot of work to change the narrative among family members. So to me, that feels kind of like the next frontier. It's like really working with families and systems to really tackle it that way.
And I don't know, any thoughts about like where you would want to see drug policy? Is that just seeing everything with like decriminalized and take on a more harm reduction approach?
Absolutely. Yeah. I think it's time.
Where do you think some of the work is right now in that realm? Like, yeah, if people wanted to get involved or get like an idea, like how, like where's an area to focus on, I guess is what I'm trying to ask.
Getting involved with like local harm reduction agencies. So in New York, it's easy because there's so many. There's a Harm Reduction Coalition, the Drug Policy Alliance. There are organizations like Vocal, Lower East Side Harm Reduction Center. So I just think getting involved at like the community level and supporting, even volunteering at, syringe exchange programs, just to understand what this looks like. And I think safe injection facilities hopefully are going to come to New York and the country soon, because I think that's very much needed.
Is there an initiative for New York? I know I saw something that they're trying to get something set up in Denver.
I've heard talks that they're looking at it in New York City, or they're starting to really think about what that might look like, but I don't know much about it yet. It's still pretty preliminary. Yeah.
Awesome. Just being conscious of time. Is there anything that you'd want to close with, or like any upcoming trainings or any last piece of advice that you want to share?
I think if people want to learn more about what we're doing, they could go to our website, which is centerforoptimalliving.com. We have info about our services, our upcoming trainings on the training tab. I'm just excited to see that people are much more open to what we're doing, and it doesn't feel so fringy at this point, and that there is more openness to it. So I feel hopeful.
Yeah, I think we feel hopeful too on the psychedelic side of things too. It's like we got people that, just really interesting stories coming out of the woodwork being like, hey, I'm really interested in all this all of a sudden. It's like, how do we... It's exciting, the future.
Yeah, we have to rehumanize the treatment process for people.
Yeah, exactly. Yeah. Awesome. So the centerforoptimalliving.com, people can find that. And then if people are interested in the training, I think you have a training tab right on top there, and they can look right there. Exactly. Awesome. All right. Well, thank you so much for having me. Yeah, thank you. Yeah. It was great chatting with you, and we'll talk soon. All right. I hope you all enjoyed that episode with Dr. Jenifer Talley. This is a little bit different episode. Just it was more general in drug policy and drug harm reduction. But, I hope that you enjoyed it. You're able to take some good tips away, things that you could possibly implement into your own life of maybe how to support somebody that's going through this, or just maybe even how to just be a little bit more compassionate with people that that might be using substances, and maybe you're worried about them. So how could you develop a good relationship with people and really show that you care about them instead of trying to force them into making decisions that might not work for them? Abstinence can never say that word for some reason, is obviously the safest form of harm reduction, especially when it comes to substances that carry like a lower safety profile. But obviously we adults are left to their own choices, and we can make those choices. But how could we really just reduce harm for people that are engaging in, say, risky behaviors or, substances? Because at the end of the day, we're all human, and we're all kind of we're all dealing with stuff, and people cope differently, and and how can we connect to that humanness with people that might be using? So, I think one big takeaway from this episode is checking our judgment about like people that are engaging in, say risky behaviors or certain substances. How can we really check our judgment there and just show up and be human with them and show some compassion? I know that's probably really hard to do. I know it's probably difficult in family situations where there's a lot of emotional attachments there, but it's something to consider. I hope you guys enjoyed it. If you guys have any questions, feel free to reach out to us at psychedelicstoday@gmail.com, and we'll catch you on the other episode. Thanks so much for listening.